It is my pleasure and privilege to be with you today at the Iran International Congress for Metabolic and Bariatric Surgery. And thank you, Muhammad Kerman Sarabi, for the kind invitation. And hopefully, I could be with you in person next time. I have fond memories of Tehran. I grew up in Tehran when I was a young boy. My father, late father, used to work in Tehran, and I have memories of Niavaran and Shiraz and many places. And hopefully, I could come and visit you next time. This is my disclosure slide. It has no bearing to the presentation. It shows the types of procedures I currently perform. No financial disclosures. Today, I want to talk to you about three things: surgical quality from the perspective of the American College of Surgeons and the American Society of Metabolic and Bariatric Surgery, the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program. I'll talk to you about quality improvement in bariatric surgery and then conclude by talking to you about how we can create value in our field for our patients. The story of surgical quality in the US, which is currently the American College of Surgeons, NISQIP and MBSAQIP and TQIP programs, starts with the late Shukri Khoury in 1991. Shukri Khoury was a cardiothoracic surgeon at the VA in Boston, and he was tasked with looking at outcomes of metabolic and bariatric surgery and trying to improve them. He worked with two residents to create the quality improvement program, and this program is what has led currently to the ACS network. Fast forward to 2007, the US had two different bariatric surgery quality improvement accreditation programs. The one led by the American College of Surgeons on the left, called ACS BSCN, and the one led by ASMBS through the BOLD database, it used to be called the Center of Excellence. Many of you are part of it as ICE internationally. In 2012, April 1st, both the American College of Surgeons and the American Society of Metabolic and Bariatric Surgery joined forces to create the current program that's in the US called the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program. And this is how centers and sites get Center of Excellence accreditation. This program currently has more than 880 hospitals, including international sites. And when I was in Abu Dhabi, I had the distinct pleasure and privilege to be a data reporting site, the first one for MBSAQIP, and we used to get reports every 6 months. So for instance, this is the report we used to get when I was in Abu Dhabi. It's a risk-adjusted report that comes every 6 months that looks at data over a year. And this report not only gives you areas where you're doing well, shows you areas, more importantly, where you're not doing well. And this data is risk-adjusted, so you could truly trust the results of the data you're getting. One other advantage that I use in my clinic every week for patients who are seeing me for the first time, or for patients who are seeing me either before surgery or after surgery, is this MBSAQIP risk calculator. This is a risk calculator that you can use for your patients. It's available online. You could actually look it up yourself, as we say, Google it. Just type in MBSAQIP risk calculator. You get to this page. You can put the patient's age, gender, BMI, medical problems, and procedures they're interested in having or have had. And then what you get is this report. So first, it shows you their weight loss in the first year, if they had a band, a sleeve, a bypass, a duodenal switch. And you can use this after surgery to follow their weight loss, or before surgery to anticipate what their weight loss would be and help them in procedure choice. In addition, you get their BMI change over a year. You get improvement in medical problems in each procedure separate. So I plugged in here high blood pressure, high cholesterol, sleep apnea, diabetes, reflux, and it shows you each procedure: band in green, sleeve in red, bypass in blue, or duodenal switch in orange, and their different improvements. So the patient can get a real assessment based on their own risk profile. And most importantly, for high-risk patients, you could get the risk of complications. It includes risk of death, major or minor complications, and specifically risk of leak, reoperation, bleeding, infection, readmission, or reintervention. And this allows the patient to make an informed decision about the surgeries they choose. The second part of my presentation is talking about quality improvement, and I want to show you a story and a journey we took about 3 years ago. So our semi-annual report came 3 years ago showing that when it comes to Roux-en-Y gastric bypass, in that particular calendar year, we did 307 cases, and that our reintervention rate was 3.3%, which was higher than expected. Now, you could look at this and feel bad about it, but do nothing. But then what is important is that you do something about this report. So what we did is we pulled the cases to look at. So quality improvement starts by looking at data, trying to compare this data to benchmarks, and then acting on the data. So what we did is we looked at all the cases that had reintervention. We found that most of them was re-endoscopy, 10 re-endoscopies in 319 cases. We found that 8% was in circular stapled anastomosis, 1% was a linear, 0% when hand sewn. So we knew that there is something to be had with circular stapled anastomosis. And we found that the most common two reasons were marginal ulcer and obviously stricture. What we did next is we embarked on a study. So we had our statisticians query our electronic medical record for anybody who had a gastric bypass over initially a 5-year period, which we extended to a 10-year period, which I'll show you, and looked at more than 1,000 patients who had gastric bypass and evaluated anyone who had an endoscopy, whether by us or by any other group outside of our offices, but within our healthcare system. What we found was that about 20% of patients who had circular stapled anastomosis had an endoscopy versus 14% with either linear or robotic hand sewn. We found that the marginal ulcer rate was higher in circular stapled anastomosis and that the stricture rate was also higher. And this was our task to look at what we need to do. For instance, this was our first publication looking at the rate of marginal ulcer in patients undergoing gastric bypass. So as I told you, we compared robotic hand sewn, circular, and linear, and we found that the rate of endoscopy, rate of marginal ulcer, and rate of revision for marginal ulcer was higher after circular stapled anastomosis. Our surgeon who performed circular stapled anastomosis used a 25 EEA, so this was not the reason. We know that 21 EEA have a higher rate of stricture than 25, so that was not the reason. But then we also looked at whether it's anticolic versus retrocolic. There's literature to show that anticolic EEA could have a higher stricture rate. The second thing we looked at is looked at the rate of stricture after gastric bypass. Again, we found that the rate of stricture was higher in circular stapled anastomosis compared to linear stapler, about 4.9% in circular and less than 1% in linear stapled anastomosis. Then we looked at our data over a 10-year period, and we compared circular staple to linear staple to hand sewn, and the results are quite similar. Rate of endoscopy and marginal ulcer is higher in circular stapled, and it's similar in linear and hand sewn, and the rate of revision is the highest in circular staple, followed by linear, and the lowest in hand sewn anastomosis. Then we carried these one step further. We wanted to look at the effect of pouch size. So we looked at all patients who had an endoscopy, excluded anybody with a stricture, and looked at patients who had a CAT scan at the same time, and measured the CT using CT volumetry, the pouch size. And we found that the pouch size was larger in patients with a marginal ulcer on endoscopy compared with patients who did not have a marginal ulcer. We also found that every increase in pouch size by 5 cubic centimeter more than doubles the rate of marginal ulcer. So as you can see, you can go from identifying reintervention and gastric bypass as an issue to digging deeply in it to identifying issues that pertain to pouch size, pertaining to technique, and our surgeons are working on ways to try to improve their technique to decrease these findings. We also found that our threshold to performing an endoscopy maybe was too high in certain patients, and we worked on improving that as well. I want to conclude by talking to you about how to create value for our patients. As you know, the value equation has quality and service at the uh, uh, top of the equation and cost at the bottom of that equation. So we have done an effort to try to look at reducing cost in sleeve gastrectomy and gastric bypass. So between 2018 and 2020, we asked all our surgeons to look at what they use for their patients and to try to have efforts to improve uh, the cost for their patients. So what we did to do the study is we used the cost of sleeve gastrectomy as the standard, as we call the 1.0 line, and we calculated the cost of gastric bypass compared to this mean cost of sleeve gastrectomy. So we compared each surgeon's cost to that mean, as well as each surgeon's gastric bypass cost to that mean. And we used data on 1,258 patients to do that. About 660 patients were before we made our efforts to improve cost, and 600 patients after we made these efforts. So what we found was there's significant variability in cost of gastric bypass among surgeons, and much less variability in cost of gastric bypass, cost of sleeve gastrectomy rather, among surgeons. We also found that circular stapled anastomosis was the most expensive technique, followed by linear, and hand-sewn anastomosis was the least expensive technique. So if you see here in this graph, a bar graph, so on the left is the cost of sleeve gastrectomy, and you can see it's lower than the cost of gastric bypass, and you can see over time there was improvement from before the clinical optimization project to after, but the improvement in sleeve was not significant. While when you look at the improvement in gastric bypass, it was quite significant compared to sleeve gastrectomy. The second thing is you can see that there's not much variability in the cost of sleeve gastrectomy between surgeons or a long time, but you can see a comparison of circular stapled anastomosis on the left, linear on the right, and hand-sewn in the middle, that the cost of hand-sewn is much lower than linear, and the cost of linear is much lower than circular stapled anastomosis. What we also found that if you look at the ingredients of how surgeons rather perform their surgery, that staple line reinforcement is the #1 driver of increase in cost. And we found that if you do 500 cases and you eliminate staple line reinforcement, you could save $500,000. In addition, we found that the most cost reduction in gastric bypass is done by looking at the number of staplers. So when you use more staplers, more stapler cartridges, you not only create a larger pouch, you also could lead to a higher cost as well. And also reduction in staple line reinforcement would lead to an improvement. We looked at everything, including what vessel sealer the surgeon was using, ports and length of stay and so forth. And using all this, we created a dashboard. And the beauty of this is a dashboard, although it's not risk adjusted. It is a dashboard that we share with our surgeons every other month. It gives them access to how they're doing. In the dashboard, we look at morphine milligram equivalents for each patient that was given over that period, readmission, pain scores is like a scale from 0 to 10, and cost of the procedure. And using this dashboard over the last 3 years, we've been using it since 2019. We've been able to actually improve our outcomes. We initiated a opioid reduction program, and as I told you about the cost reduction program. Over time, you can see that our morphine milligram equivalent have improved. Our readmission rate stayed the same. Our pain score stayed the same, and our cost has improved. So between 2009, 2019 to 2020, 20 to 21, and 21 to 22. Overall, you can see our morphine milligram equivalent per patient improved from 44 MMEs per patient to now 21 without a significant increase in the pain scores and keeping the readmission rate around the same, and as well as reducing the cost of surgery. So you create value by not only improving quality of care, but also reducing costs. And I think what's important is the service component. And this is something for another time to talk about efforts we're doing at patient-reported outcomes. The takeaway and the conclusions are that in the US, the main surgical quality program is a combined program by the American College of Surgeons and the American Society of Metabolic and Bariatric Surgery. It's called MBSA-EQUIP. Please check out the MBSA-EQUIP Press Calculator and see if it will help you to use for your own patients. Risk adjustment is key when you compare outcomes. You cannot compare outcomes between surgeons, patients, or procedures unless you perform robust risk adjustment. And the Achilles heel of MBSA-EQUIP is risk adjustment. And then finally, we are in an era where it's not enough to have high quality. To create real value, you have to have high quality and lower costs. Again, I want to thank you for the kind invitation, and I hope and certainly wish that next time I will be with you in person in Tehran. Thanks again for the kind invitation and for listening. I'll be happy to answer any questions. Thank you.